showing up. Yay. All right, we're going to get through about half of this talk. We'll do it in two parts. Hepatitis B is a fun topic. It's also fairly complicated and can get nuance filled to the point of being boring and not being a wonderful, interesting talk. So we'll try to keep it light, and please interrupt me and ask questions or comments are always welcome. Drew. All right, so what's different about hepatitis B right off the bat than hepatitis C? Twofold. Number one, we've known about it about 30 years longer than hepatitis C, and it's a DNA virus. And that's problematic from the start because it's can incorporate into our own genome and never really go away. Actually, that was an incorrect statement. I shouldn't have said incorporate into our genome. It can persist intracellularly forever and can cause all sorts of interesting phenomenon like we'll talk about. It's like, it reminds me of the Katy Perry song, Never Really Over. It can come back and haunt you down the road. It's a small virus, but it really puts its genome to good work. And I'm not one of those people that likes to spend a lot of time on the genetics of the virus. However, it's actually fairly important. And so we'll talk about them real quickly. It only has about 4 genes that we need to know about. And one of them is the surface protein, it's called the surface antigen. And that's all you need to know about it. That's its glycoprotein, it's surface glycoprotein. There's then 2 other important proteins, one called the core protein. And I think the only thing you need to know about that one is it is retained within the infected hepatocyte, so you cannot measure it in peripheral blood. And so whenever we're checking blood tests on the presence or absence of a core, we're always checking for the antibody, not the antigen. So for everything else, you can check both the antigen and the antibody. Now, very, very important for hepatitis B treatment implications is this additional gene named the precore. And it's terribly named. I wish it was named the E gene, but it's not. It's called the precore, which leads to all sorts of confusion. But basically the precore gene codes for the E antigen. And if you can remember that one fact, that will set you about 5 years more advanced than I was for the first 10 times I read about hepatitis B. So just remember, if you read the word precore, it's actually talking about the E antigen gene. Okay, so you'll read about things called precore mutants, and rationality would assume that that has something to do with the core. It doesn't. It has to do with the E antigen. Okay, so if I say that word precore mutation, it means somebody who no longer makes an E antigen, but could potentially still have an infectious virus. Okay. The DNA polymerase is the 3rd gene we'll talk about, 4th gene we'll mention. And it's important because it explains a quirk of nature. If you talk about the treatments, which is going to be the second half of this talk, for hepatitis B, you tend to talk about using antiretroviral therapies. So using false substrates that work on an RNA to DNA dependent polymerase. And it wouldn't automatically make sense why they would be active in a DNA virus. But it's a quirk of nature that hepatitis B copies its own genome through an RNA intermediate, which is completely different than we do. Remember, as eukaryotes, we copy our DNA with high fidelity right to another DNA. So DNA dependent DNA replication. RNA is known to be problematic when it's copied. And if you're a virus, you don't care. You don't care if 50% of your progeny are altered or non-viable. In fact, having an error-prone copying of your genetic material may allow for mutation. And when you do something a couple 100 billion times a day, mutation is potentially equal to survival. So that's one of the, you never know the why nature does what it does, but copying DNA to RNA, then back to DNA as a mechanism of replication is interesting, number one, for all those whys, but also from our perspective as clinicians, it's cool because we can actually use retroviral therapies to treat a DNA virus. Awesome. And then the last gene that matters is this X protein. And it really matters because it's what supercharges hepatitis B to become a really mega oncogenic virus. So if you remember hepatitis C, we always talk about hepatitis C's risk of causing hepatocellular carcinoma. And we talk about having to progress through stages of cirrhosis, scar tissue formation, ongoing inflammation, healing, etc. So it's really a very chronic process with hepatitis C that leads to oncogenesis. For hepatitis B, it can progress. Hepatitis B can make a patient go to hepatocellular carcinoma much, much earlier and without having to go through the requisite fibrosis and scar tissue and cirrhosis. So pretty darn scary. And why? The why there is because it carries an oncogene with its genome. And so it's one of the wickedly oncogenic viruses. If you think about very oncogenic viruses, you think of like Epstein-Barr virus and HPV and hepatitis B. Those are viruses that scare me a lot. Transmission. So transmission is very interesting. And I tend to, in my own mind, lump it like hepatitis C, but it's not. It actually is more like HIV for multiple reasons. So blood and body fluids are the mechanisms of transmission a lot. You can see it's in a lot of body fluids. It's interesting, it's in breast milk because breast milk is actually, or I should say breastfeeding is not prohibited in the setting of having hepatitis B. So it's an interesting quirky fact there, but it's all over the place. And we can definitely see it from drug use. But the other thing that is far different from hepatitis C and much more like HIV is that this is a sexually transmitted infection. In fact, a commonly sexually transmitted disease. So much so it's the predominant mode of transmission in a lot of countries around the world, including the US outside of the IVDU population. The other thing that's very different in transmission in Hep B versus Hep C is the rate of perinatal transmission. So remember for hepatitis C, mother to child transmission will quote about 5 to 6% from mother to child transmission of hepatitis C. If the mother has HIV, that can increase to maybe 10%. If we move to hepatitis B, let me clarify that last statement, by the way. The HIV with Hep C, the rate of transmission of hepatitis C when you have an HIV co-infected mother is about 10%. HIV transmission of mother to child, by the way, is maybe 30 to 40%. Hepatitis B is a whole nother animal, and its transmission rate and risk, if we do nothing to mitigate it, is about 90% from mother to child. Now, that being said, there's some really cool tricks we can do. It's also the second half of the talk, so I don't want to let the cat out of the bag too much, but it can really be modified to the point where transmission mother to child shouldn't happen much. Hey, like all these viral hepatitis, they have a long incubation period from time of exposure to time of onset of clinical illness, which is unfortunate and also scary if you have an exposure because you got to wait a long time until you're sure you don't have it. So anywhere between 6 weeks to 6 months. So, and I'm not an epidemiologist, but I'm going to tell you some cool facts about it. It's a fairly low prevalence disease in the US. It sort of mimics hepatitis C very similar rates. So it's interesting, all of our chronic viral infections, HIV, Hep C, and Hep B are similar in terms of percentage. Hep C is probably the most common, Hep B number 2, and HIV number 3. I don't think these numbers are right up there, these 150,000 new infections per year. When I had looked at the CDC website, they had said more like 20,000. So I'm not sure what the answer is there, but there's too much. Because remember, this is a vaccine preventable disease. And we really would expect it to be much, much less if we caught patients up who had risk factors for it with vaccination. And I also talk about the vaccine indications in the second half of this talk, but it's certainly part of routine vaccine schedules nowadays for youngsters. It's just we have a lot of unprotected adults at this point. And this is how it's very different than hepatitis C, is that for Hep B, sexual activity is one of the major ways in which people can acquire Hep B. Remember, sexual transmission for Hep C tends to be almost exclusively in the MSM, HIV positive population, tends to be where the highest risk for Hep C, sexual transmission, where for Hep B, it's a commonly sexually acquired process. And perinatal, as I mentioned, in some parts of the world. So it can come from injection drugs because of percutaneous exposure, as well as, blood-rich environments like hospitals, hemodialysis centers, etc. And the same household warnings that we give patients who have hepatitis C, we should also tell patients with Hep B. So tell them not to share toothbrushes and razors or anything else that would potentially share blood. This is an interesting slide, so if you talk about the epidemiology, or I should say the statistics on the incidence of Hep B countrywide, it's actually declining. Except for, there was an except for in there, and I'm sure everyone in the world is tired of hearing the except for and then the word West Virginia in some negative sense. I know I am. But it's unfortunate that we have that distinction along with Tennessee and Kentucky as having an area of increasing hepatitis B prevalence. And that's again because of the opioid epidemic. Internationally, hepatitis B, I cannot underemphasize what a massive problem it is. And I'm not an expert from an international standpoint on any form of epidemiology, but I will say that I've read statistics that 2 billion people, I don't know how many billion people are on the planet, but I think it's 7 or 8. I haven't looked at that world population clock lately, but that's pretty bad if I'm off by 1 billion, by the way. So forgive me. Oh, I was 1 billion off. But the maybe 2 billion people have been exposed to hepatitis B. That doesn't mean they have it actively. You can see about 350 million actively still have it. So that's a major issue. Now, if you look at sort of strategies across the world to deal with this, the vaccination has been rolled out, but it's largely being rolled out systematically to youngsters, to children. And there's a huge catch up that needs to be done. And so we're not gonna see a major impact for quite some time, perhaps a lifetime. The issues with transmission is, whereas we talk about in low endemicity areas like the US, it's primarily sex and drugs and blood exposure. The major risk factor by far in the high prevalence areas is mother-to-child transmission. I have a ton of patients in my clinic who are born in other countries who have no risk factors other than being born. And usually their mother has no knowledge of her serostatus. There's a really unusual fact about hepatitis B as well, that if you want to freak yourself out, you can read about it sometime. But it's maybe even possible for a hepatitis B positive father to transmit hepatitis B to his unborn child, even without infecting the mom. Too detailed for me to talk about, but it's wild and it potentially happens. Thoughts of perhaps is it transmitted with the sperm itself versus early childhood transmission, that's debated. But anyway, vertical transmission is the problem worldwide. And it's, it's terrible. It's terrible. because again, this is a vaccine preventable illness. It's just taking too long to catch up. But again, a lifetime from now, when all the youngsters who have gotten the vaccination across the world are now of childbearing age, this slide will hopefully be a fossil and no longer pertinent. When you talk about hepatitis B, acute illness and then chronic liver disease are the two issues. We call it chronic hepatitis B after 6 months, so the same as hep C. The interesting thing about risk of going on to chronic infection is it really depends upon your age of exposure. So if you're an adult when you're exposed to hepatitis B, very infrequently do you get chronic hep B. So that's completely different than hep C. So hep B, if you're exposed to an adult, most of the time you clear it, 95%. And that's as opposed to, the maybe 70 to 80% for hep C who get exposed as an adult. The problem is in the perinatal period. So in mother to child transmission, the rate of development of chronic hep B is very, very high. Almost 90% of people will go on to, who get exposed, will go on to keep hepatitis B with time. The clinical manifestations, if you remember, the exact opposite of that. So usually these babies born to hepatitis B positive moms don't have any symptoms. They don't get a clinical jaundice episode or have any transaminitis, but they'll just go on to carry hep B silently until they have a child someday down the road and pass it on as well. However, for adults, if adults are exposed, they tend to be more likely to have symptoms. Now that's still not the majority. It's still only about a third of people, but it's probably higher than the rate of acute hepatitis C. Okay. In terms of the clinical illness, as I mentioned, most have a subclinical. Some can develop, about a third develop a symptomatic hepatitis. There is a potential to progress to a fulminant hepatitis. And it's very rare, very, very uncommon. It tends to be in somebody who has other risk factors such as concomitant hep C, has hep D, has some other chronic liver disease, but it can just happen. It can just happen. It can, of course, progress to cirrhosis once it's chronic liver disease, and then developing hepatocellular carcinoma. Remember, we talked about that X protein, and that can be an issue. Even without cirrhosis, you can get cancer even early on. And by the way, the risk of hepatocellular carcinoma tends to be ethnicity and gender dependent, with females being lower risk than men, and those of African descent being of higher HCC risk from hep B. The clinical signs and symptoms of acute hep B are identical to any acute hepatitis. So you get GI symptoms and generalized malaise type symptoms first, and then you would develop your jaundiced appearance. And it can be a prolonged illness, maybe up to a month or so. The fulminant hepatitis would present, as you'd imagine, as a very jaundiced illness, encephalopathy and coagulopathy. Chronic hep C does have very similar manifestations as hepatitis C does. So chronic hep B has very similar extrahepatic manifestations. If we think of hep C, we always talk about potential for autoimmune diseases, immune complex deposition, vasculitis, joints, etc. Those are mimicked almost perfectly by hepatitis B. I will say that hepatitis B in its early phase has a really strong propensity for vasculitis that's perhaps more aggressive than hepatitis C's vasculitis, a much more necrotizing vasculitis. And so one of the ways that we find out about hepatitis B is people presenting with abdominal pain or infarcts to various organs, and then the pathologist will tell us there's the vasculitis, and that will lead us to a reverse diagnosis of hep B. But by the way, sorry, I should have gone 2 slides back here. During the acute hep B infection, one of the best descriptors I heard this is that it often seems like a serum sickness. So it's somebody who gets an urticarial rash, achy pains all over, a lot of joint pains, maybe low-grade fevers, and then development of a jaundiced appearance. And the jaundiced appearance does not obviously occur with serum sickness, but it's something, if you're ever going down that pathway in your mind of working somebody up for a serum sickness-like illness, remember to check your hepatitis B studies. In terms of lab tests, during acute Hep B, transaminases usually in the thousands and then declining over time. Bilirubin can be quite elevated. And if you say, who's going to go into liver failure, look at the PT9R. So the laboratory studies for diagnostics, I'm going to try to, actually, Mitra, do I have time to do these or should I stop?
It's totally up to you. We have 2 minutes until 1:15, but I'm totally fine going until you're ready to end.
I'll probably hold and then not rush it through, because these are a little bit nuanced and I don't want to miss the message. And I'll have about 20 slides left for the next didactic, and I can do it. Are there any questions or comments from the field about the basically acute or chronic manifestations of Hep C, or the differences between Hep B and Hep C? Kind of fascinating that this is a vaccine preventable illness that's still causing so much morbidity and mortality worldwide. We're very lucky in the US not to suffer with the vertical transmission issues, but certainly Asia and Africa have a major seroprevalence issue still in unvaccinated adults, and tons of hepatitis B that are leading to long-term morbidity. And unfortunately, and again, I'll talk about this the second half of the talk, this is not necessarily a curable disease. Being the DNA virus, it's something we can control, but we're not going to have the same blessing as we do with direct-acting antivirals, where we're going to be able to treat somebody with certainty and be able to put this behind them for good. We can control it and induce immune tolerance at best. So, or immune control to actually be a better term. But any questions? I don't want to rush you through the serology and the treatment. I'll talk about those the next time if that's cool.
Yeah, absolutely. Thank you, Dr.
Could you go back? Okay. And could you go back about 3 slides?
That one, Tammy?
Let's see, one more. I think that one. Hold on 1 second. Let's see.
So what this one is saying is that most people who get exposed as adults, while adults are much more likely than neonates to have symptoms, it's still the minority. It's about 1/3 of people that actually have clinical hepatitis.
Okay.
And again, the nice thing as an adult to be exposed is you're about 95% likely to beat it on your own. As opposed to kids, you're exposed, you don't really get symptoms, but you get chronic disease.
Are there any other questions for Dr. Gilfus? And while he has his slides up, we can advance back or forward as well.
Well, Mitra, thanks for letting me run the slides. I'll hand it back over to you. You're much better at this than I am.
Oh, no, not at all. Absolutely. I'm happy to help in any way, and I had it as backup just in case. So, but all right, we're at 116 actually. So thank you all so much. Thank you, Tammy, for those awesome cases as always. And we do encourage any of you guys to submit cases or questions as well that you have for the group at any time. So definitely don't hesitate to do that. I attached the direct link to the online case forms and the recap emails and the reminder emails. Thank you, Dr. Gilfus, for that awesome didactic. I'll follow up with you for part 2 for sure. A couple housekeeping announcements. So we actually will not meet on November 26th. That one is canceled for Thanksgiving. So next time we'll meet is on December 10th, and Carolyn Kidd will be providing the didactic for that session. So keep an eye out for that reminder. I hope you all have a wonderful and safe Thanksgiving, and we'll see you guys next time. Thank you.